Okay, so this is a talk about ALS mimics. Obviously, it's kind of impossible to talk about ALS mimics without touching on ALS itself. But this is really intended to be a very clinical talk that I hope will be useful to everyone, going through different cases to talk a little bit more about the differential diagnosis of ALS. It will not be too much about management of ALS or things along those lines. And so the basic outline, as I said, really have to talk a little bit about ALS in order to talk about the mimics, and we'll talk a little bit about just the difficulty with the diagnosis of ALS, how it's made, and then go through a series of cases. This is not intended to be super comprehensive. We won't be able to touch on absolutely everything that can mimic ALS, but I'm hoping that each of these cases will give you sort of a different teaching point that we can then go through in more detail. So I don't think I need to tell this audience too much about ALS. It is obviously a devastating neurologic disease. With ALS, because the life expectancy is so poor, it makes more sense to talk about incidence than prevalence. And you can see here, it's about 1.8 out of every 100,000. If we're talking about just the risk of dying for men, there's slightly higher incidence in men. And so it's about a 1 out of 350 risk of dying from ALS for men, and 1 out of 420 for women. A little bit lower in non-whites. And so it's not all that uncommon. And one of the really devastating things about it is that this is a disease that affects people kind of in the prime of their life. So the average age of onset is 56 years of age. And then the average life expectancy, usually we say about 2 to 5 years, but less than 5 years from onset. Most ALS is sporadic. There's probably up to 10% of ALS is familial, but for most people, it's going to be a sporadic disease. And so, again, I won't belabor the clinical features of ALS. I think everyone's fairly familiar, but the classic description of ALS is really as a mix of upper motor neuron and lower motor neuron signs, right? So you get these patients who present with painless progressive muscle weakness and atrophy, and then fasciculations. Those are all lower motor neuron signs. But then they also have increased reflexes and spasticity. They may or may not have a Lipinski sign. Actually, maybe in ALS, you see that a little bit less than some other things, but just kind of increased reflexes in general. And then ALS is really kind of a segmental disease. And I'll get a little bit more into what that means when it comes to the diagnosis. All of my images that I'm going to use, I have the full citations at the end of the talk. This is actually, I don't know if anyone here reads Hindi, but this is from an Indian journal, that it was one of the best depictions that I could find of one of the sort of characteristic features of what's called the split hand sign. And so this is kind of an example of a lower motor neuron pattern. And so what you see is basically, it's a little bit harder to see the thenar eminence. It has some atrophy there, but you can quite clearly see in the bottom picture that the first dorsal interossei is pretty affected. However, adductor digiti minimi is not affected. And so this is kind of characteristic of early in ALS, where for whatever reason, even though FDI and ADM are both ulnar innervated, both C8, T1 innervated, the disease preferentially affects FDI. And so this can be something pretty useful in clinic when you see this pattern, as opposed to somebody who's got wasting in both FDI and ADM, and maybe also has some tingling in the fourth and fifth digit, more suggestive of an ulnar neuropathy. And this is again a different depiction of that. And so again, the split hand sign where you've got FDI, and here you've got some nice arrows and ADP that are affected, but then ADM is spared, and they've got that dashed line to indicate kind of the divide between the two, hence the split hand. This is actually from a study that was attempting to sort of use this as an electrophysiologic parameter helpful in the diagnosis of ALS. So, the equation they've got at the bottom, I won't go into too much detail, but essentially they're using the CMAP, so the motor response recorded over those different areas to sort of quantify this. And there have been some studies that have proposed using this. In clinical practice, I don't think it's really been picked up too much so far, but it's kind of an interesting concept. And so getting a little bit more into the contiguous spread of ALS and what that means. So this, the next couple of slides, I'm going to be showing these images from a recent paper in neuropathology. So this is it's a neuropathology paper, so a little less clinically focused, but I actually thought these diagrams were pretty great. I also think the expression on the face of the little stick figure is appropriate, where he looks appropriately scared with this awful disease. And so what you see here is kind of the classic picture of ALS, where it might start in an arm or a leg. And then you have hyperreflexia, even in that affected limb, maybe outside of that limb. And then as it spreads, it usually spreads to adjacent areas along the spinal cord, and eventually will affect everything. But here's the problem with ALS. I mean, the diagnosis in many ways would be easy if everyone just presented in that fashion, but the difficulty is that that is not always the case. And so, you have from this same paper, different types of variants. I certainly can't say I've seen all of these. Some of the ones they have here are pretty rare. I mean, they've got some crossover phenotypes with like spinocerebellar ataxia and things like that. But certainly, there are, for example, flail arm syndrome, where kind of both arms are affected at once, gives kind of a man in the barrel phenotype. And another name for that is brachial amyotrophic diplegia, or BAD. I've definitely seen that one a fair amount in ALS clinic. And for example, for that one, the survival seems to be a little bit better than other phenotypes. And so, and then you can see even some of these, the survival might be more prolonged, where you get into the hemiplegic form and you're talking about greater than 10-year survival. And so when you're taking a history and you find out that symptoms began earlier than you might have expected, with them still surviving, this is where the diagnosis of ALS can get quite tricky. And when you think about ALS, there's really a spectrum of ALS. So in the center of this diagram, you have you go dead center, you got the classic ALS. So just a perfect mixture of lower motor neuron and upper motor neuron. And there's some debate about exactly to what extent these are different diseases or not. If you have sort of a cousin of ALS in which there are only upper motor neuron signs. That is called PLS, or primary lateral sclerosis. And if you have a form that only has lower motor neuron signs, we call that PMA, or progressive muscular atrophy. However, even within ALS, we might refer to some ALS as upper motor neuron predominant. So maybe their patient is mostly spastic, including with often like a spastic pattern of speech or other things, but they've got a tiny bit of atrophy or a tiny bit of fasciculations. And so, again, when you get more to the extremes of this diagram, that's where the diagnosis gets tricky. And this has, of course, led to misdiagnoses. And so there are a number of studies on this. The diagram I have here, it's from an old study, but I think it's a pretty good one from Brian Traynor and his group. They're the Irish ALS register study. There are some differences between our health system and Ireland. It sounds like in their system, neurologists are acting in much more of a consultant role, might not be following patients as longitudinally, but in that study of patients, kind of list of everyone in Ireland with ALS, going back, they found around 7% were misdiagnosed. Scottish study, pretty similar setup, found about 8%. And then interestingly, there was a more recent study that this group with Jacobson and some colleagues did at the University of Michigan, which is a very renowned neuromuscular program. And this was actually patients who had been diagnosed by neuromuscular neurologists and still found about a 3.9% misdiagnosis rate when they went back and retroactively looked at what the final diagnosis was. And you can see the diagram on the left is from the Traynor study, and they show some of the things that had been misdiagnosed, and we'll go a little bit more into some of this in various slides. I do have to say hyperthyroidism being on that list is that's a little bit baffling to me, but nonetheless. On the other hand, there's misdiagnosis that happens in the opposite direction. And so this slide, the diagram's a little bit busy, but basically this is from a review paper that looked at a number of studies kind of showing the misdiagnosis. And they went through 21 retrospective studies. What they were really looking at was the diagnostic delay with ALS. And you have there just things that people were originally diagnosed with before they were found to have the diagnosis of ALS. And importantly, in this paper, they found that the average delay in diagnosis was about 10 to 16 months. So that's obviously important clinically, and it's also important for research purposes. And one of the reasons I think that ALS has been such a challenging disease to make a difference in when they're looking at drug trials and things along those lines. In this study, when they look back, there was an average about 3 to 6 months before patients saw any physician. That includes their general practitioner after their symptom onset. Part of that is probably just due to patients trying to ignore their symptoms, or perhaps not having an established provider. But nonetheless, even after seeing a physician, it was only about 6 out of 10 that were referred to a neurologist, and 40% were referred first to other subspecialties, which included rheumatology, orthopedics, various sorts of surgeons. And so when we talk about the diagnosis of ALS, and I have this conversation with patients all the time, the challenge, in addition to the complexity of it, is just there's no biomarker, there's no blood test, so I can do a blood test that says you have diabetes, prediabetes, or nothing. There's nothing similar for ALS. And it's really is a clinical diagnosis that is supported by EMG, and then ruling out other causes. Just to comment on the EMG part, because I think that this is something that comes up a lot of times. EMG does not diagnose ALS. ALS is a clinical diagnosis that is supported by EMG. And so there have been times when I've seen patients who have randomly had an EMG and then come, for a question of ALS. For example, I had a gentleman recently who presented to his primary care physician with fourth and fifth finger tingling, numbness, kind of bilaterally, and they noticed that he had some atrophy of the first dorsal interossei. Of course, on close exam, he also had atrophy of adductor digiti minimi, but sometimes that's a little more challenging to appreciate. And he went on to have an EMG by an outside provider. It was actually a therapist who did the EMG. One of the more extensive EMGs I've ever seen, maybe like upwards of 50 muscles that they did. And they found membrane instability kind of across the board and sent him to me saying, he's got ALS, please discuss with him. And so it's a tricky diagnosis to undo as well, but clinically this patient's picture didn't fit. Still trying to figure out exactly why he has so much membrane instability, because when I repeated the study, that did occur as well. But there are other things, for example, channelopathies and other things that can produce that picture on EMG. And so you can't just take the EMG out of context is the big point. So I'm going to go through different criteria that are for the diagnosis of ALS. And bear with me for the next few slides. The point here is not to memorize these criteria. I certainly don't have them memorized. It's to touch on them and talk a little bit about some of their limitations. So the Ascorial criteria is the most commonly cited ALS criteria. It was developed in Ascorial, Spain. And the problem with it is that, first of all, only about 56% of patients thought clinically to have ALS will actually fulfill their probable criteria at the time of diagnosis. And about 10% of clinically defined ALS will die before fulfilling definite or probable criteria. They've also later looked back and looked at, okay, do these clinically possible, clinically definite, do these different levels of certainty seem to correlate with the clinical course with survival? And the answer is no. So this criteria, I think, has its flaws, but you will see this is most commonly used in research. There have been attempts to move away from it, but it's often still the most commonly used. And you will see EMG reports that reference it. I personally don't. I was trained not to, and it's just a stylistic thing, but I tend to think of this as being useful for research purposes, and again, the diagnosis of ALS being a clinical one supported by EMG. But you can see, going through the different levels of certainty, what they're basically looking for is the number of regions that you have upper motor neuron and lower motor neuron sides. There was subsequently Awaji Island criteria. All of these criteria are back in the days when people actually had, these fancy meetings where they'd go to a fun place. And so this was Awaji Island in Japan in 2006. There's controversy over this. The attempt was to try to diagnose people early. And the basic thing that they did was they said, well, the EMG is sort of equivalent to the exam. So we're going to substitute in the EMG a little bit more. And then also, instead of just counting fibrillation potentials and positive sharp waves as the equivalent of ongoing denervation, they also included fasciculation potentials. And what they said was it's especially complex fasciculation potentials that are most useful to diagnosis. And again, I won't belabor exactly what they did here, but they essentially rely a little bit more on the EMG. More recently, and this slide compares the three, there has been the Gold Coast criteria, which was developed in 2019, and it really attempts to simplify things. So it kind of gets rid of all of these other, definite, clinically possible, all those sort of subsets, and it just says, do you have a clinical history and exam that fits with the diagnosis of ALS? And do you have at least one body region where you have both upper motor neuron and lower motor neuron dysfunction? If you don't have that, then do you have at least two body regions where you have lower motor neuron dysfunction? And then they also include kind of excluding other diseases. So I think these criteria, all of them, are useful, again, for research primarily. And when you are thinking about the diagnosis of ALS, I like to use them as sort of like a fact-checked sort of thing, where I go back and I look at this and I say, okay, here's where I have my acute on chronic denervation, sort of what level of certainty do I have about this? But I don't say to the patient, you have clinically probable ALS, that's laboratory supported, for example. I just don't think that's a useful discussion. Talking about what to exclude is a little bit more challenging. Surprisingly, there's really not a whole lot in terms of consensus about exactly what panel of tests. So again, you're really going by what your clinical presentation is. You're basically always doing the EMG. Maybe they've had another that's already definite and they're coming to you for just as a neuromuscular specialist. Sometimes that'll happen, but almost always doing an EMG. And then I think how a lot of us target our testing is really driven by the presence of upper or lower motor neuron signs. And, just being very honest, I think it also depends somewhat on the patient, the family. Do you have a super young person who you want to do everything to exclude other diagnoses versus, somebody who maybe has a lot of other comorbidities, is in their 80s, doesn't want to be too aggressive. And so this is my table that I developed. This is not meant to be definitive, but just, I think it's helpful to think about, what your phenotype is. And if you have upper motor neuron predominant, lower motor neuron predominant, sort of classic combined phenotype, or more of a bulbar onset, there are various tests that you can think about, which include imaging, include labs, sometimes genetic testing of various sorts. Bulbar onset ALS is extremely tricky, just because your EMG is so limited unless it's been going on for a while, and needling the tongue muscles, for example, is really challenging. I have in parentheses there movement disorders evaluation, just because for bulbar onset, some of the Parkinsonian variants can sort of mimic bulbar onset ALS, so important just to keep in mind. I'm not going to go through the table too much because I think going through the cases will be more useful. So again, with the cases, this will not go through every sort of ALS mimic, but I think it'll, each one will sort of touch on an important point. So with no further ado, I'm going to go through them. So case one is a 68-year-old woman who presents with left hand weakness that started when she woke up in the morning, and then kind of months later, she noticed some trouble with her right foot pressing the gas pedal. And you can see from the image there that on exam, she has really left wrist and finger drop. And so what are sort of some tip-offs that tell you this might not be ALS? Because I mean, you've got somebody, they've got this painless weakness. ALS is certainly in the differential. But in this case, number one, you have kind of a stepwise progression, sort of these isolated incidents. Number two, on exam, what you're really seeing is more of single nerves being affected. So in that picture, you might have noticed with wrist drop and finger extensor weakness, it's primarily a radial nerve problem. I didn't go into this too much with the problems pressing the gas pedal, but she's primarily plantar flexion weakness, might be sort of a tibial nerve sort of issue. And so it's not that multiple parts of the leg or the arm are affected. And again, kind of the arm and then the leg on opposite sides would be a little atypical for ALS. And actually that's the next point here, that it's a non-contiguous spread. And so what are kind of your next steps or ancillary tests that you might consider? And really, this one just comes back to doing the EMG that you're basically going to do in every case of ALS. In this case, I would say the nerve conduction study part of the EMG might be a little bit more important than just a standard ALS EMG, which is going to focus more on the needle. And also antibody testing, which I'm going to get into here. So when you do the EMG, this is what you see. So you basically see conduction block that is at a non-entrapment site. So this is stimulation of the median nerve. And you see going from top to bottom, they're going distal stimulation to proximal. And so the block that you're seeing is between the elbow and the axilla, where the amplitude decreases. You've got some temporal dispersion. And so that is a non-entrapment site. It's not at the carpal tunnel, for example. And so this case is meant to be multifocal motor neuropathy, or MMN. Definitely very important to keep in the differential for ALS. So this is a disease that affects people. I guess the average age is a little bit younger, about 40 or so, as opposed to 56 with ALS, but pretty similar. For whatever reason, seems to affect males a little bit more, and it is asymmetric. It tends to be more distal weakness. Arms often more affected than legs. But it gets tricky because they can have intrinsic hand weakness, they can have cramps, fasciculations. If it's gone on long enough, they can have atrophy. So especially MMN that has gone untreated can mimic ALS. It is associated with an anti-GM1 antibody. And so in addition to your electrodiagnostics, that is really important to look for. And so I would say anyone basically I see who's got a lower motor neuron phenotype that I'm thinking about with ALS, I check that because you just don't want to miss this. This is a little bit of a busy slide. This is the diagnostic criteria for this. I won't belabor this too much because it gets a lot into electrophys, things that are not as useful for general neurologists. But basically what you want is a clinical picture that looks like what I've described. And then you want conduction block, definite conduction block, a drop of at least 50% in a non-compressible segment in at least one nerve. And there are different levels. Certainty and the elevated IgM level, again, can help with the diagnosis. But here's why this is so important. So this is a treatable disease, and IVIG is really the mainstay of treatment. It gets a little more complicated than that with refractory disease, but IVIG is primarily what you want to think of. Steroids in this disease have actually, in some studies, been shown to be harmful. And so as opposed to something like CIDP, where IVIG or steroids are probably pretty equivalent, with MMN, it's really IVIG. That's the mainstay of treatment. And so again, this is something that you can potentially at least stop from progressing or potentially reverse. So that's huge if you're thinking about ALS. Where it gets more difficult is the concept of MMN without conduction block. I won't go too much into this, but there's a related entity that has the name MAMA, multifocal acquired motor axonopathy. And this is basically patients who look like MMN clinically, but then you don't find conduction block, you don't find demyelinating features on EMG, but they still respond to IVIG. And so this gets really tricky because, gosh, you wish you could just give everyone IVIG and make them better if you're thinking about ALS. And you get into a really tricky position because, of course, the patient, the family is going to want to think they're getting better. So you really, if you're considering this, you really need to make sure you've got some objective, motor sort of standards that you can follow to see if they're getting better. But the important concept here is this still should be following a nerve rather than a segmental pattern. Because the idea is maybe that the conduction block is just in a place that you can't really stimulate. So maybe their conduction block is too proximal for you to be able to capture it on your nerve conduction study. But it's still going to be, radial nerve affected or median nerve affected or whatever, rather than, multiple muscles in that limb. Okay. Case 2 is a 57-year-old woman. So she has weakness in the left hand. It's been progressive, some difficulty grasping objects. She's got wasting, occasional neck pain, but no radicular pain, no sensory symptoms. And then your exam, you've got a little bit of forearm atrophy as well as intrinsic hand, thenar, hypothenar. And she's definitely weak. Her numbers are there. You see some fasciculations. You've got increased reflexes basically everywhere. So what are your tip-offs here that this is not ALS? The lack of split hand, potentially, although potentially ALS just going on too long might produce that. Symmetric reflexes, you can see in ALS, certainly just everything increased, but especially with the bilateral Babinski's that she's got, makes you wonder. Neck pain, neck pain is just so common that it's hard to say if that's a tip-off. And so the point of this is not actually so much that this is clearly not ALS, it's just to point out that everyone basically that you're considering this diagnosis should have an MRI of their C-spine. If they've got bulbar weakness, it's not going to explain that. But this is this patient's MRI. Again, I think it's pretty obvious that this is a pretty banged up spine, that you've got some cord signal change, multi-level degenerative disease here. And so this patient had surgery, and post-operatively did great, and at 6 months was improving with some improvements in strength. Now, she might not get all that back, but again, this is somebody who, at the very least, you stop from progressing. And so this is an example of cervical spondylotic myelopathy. And so the important point here is that really with degenerative spine disease, you can have both upper and lower motor neuron signs because you can get a combined myelopathy and radiculopathy or polyradiculopathy. And you might not have a ton of sensory symptoms. So if you're involving more of the ventral nerve roots or the anterior horn, you're not necessarily going to get those classic radicular symptoms. So it's important to keep an open mind. And again, this is something where when you're doing the EMG, yeah, okay, if they've got, C5 really affected, you're going to see changes in those muscles, but you're not necessarily expecting that outside of those muscles, you're going to see muscles affected. And again, just if you've got bulbar symptoms, then either there's something else causing those, or potentially that's ALS plus C-spine disease. You're not going to be able to explain bulbar symptoms with this. And then also to keep in mind, the reverse can be true. And so it's not uncommon that we see patients that have undergone, multiple spinal surgeries or have first been sent to see spine surgeons when in fact the diagnosis is ALS. So if you've got somebody who's really continuing to progress despite multiple surgeries, definitely if they've got bulbar symptoms or signs, and if they've got respiratory involvement, that they don't have COPD, some other explanation, you got to keep that in mind. And I think I've definitely seen a lot of surgeons here seem to be pretty good at this and sending people for neuromuscular consultation when things just aren't making a whole lot of sense from a surgical perspective. Also important just to touch on with spine issues, similar pattern can happen with lumbar stenosis, obviously, not affecting the arms. And then, polyradiculopathies and myelopathies, these are not always structural compressive things. And so this is where you come back to your clinical context. So for example, I don't check Lyme disease most of the time because in this area, Lyme disease, without a travel history just really doesn't exist a whole lot. But if I've got somebody, with a travel history, I might think about that in the right context for a polyradiculopathy. Or if I've got somebody, who has a history of cancer, especially cancer that it's unclear whether it's fully been treated, you got to think about malignancy causing a polyradic sort of process. And you just take your clinical context. And with myelopathies, the chart that I had shown of sort of things that I test, if you don't have a structural cause, you can think about things like B12, HTLV, HIV, think about copper, vitamin E, things along those lines. All right. Case 3 is a 43-year-old guy. He's got 6 years of limb weakness. And he noticed about 6 years ago, also has some atrophy, some cramping, difficulty with walking and balance. And family members have picked up that he seems to be a little bit dysarthric as well. Sorry, this kind of a nightmare picture that was compiled by putting these two images together. But this is his exam. So he's dysarthric. He's got a nasal quality to his speech. You notice some chin quivering. He's got some atrophy of his tongue. You note some gynecomastia. And then he does have some atrophy and weakness, but he's most prominently weak at the hip flexors. And then you also notice some sensory abnormalities that he really hasn't been complaining about, and decreased reflexes. So kind of your tip-offs here, you've got a long duration of symptoms, 6 years, not impossible for ALS, but a little bit atypical. fairly symmetric weakness, which is just uncommon, although some ALS variants could do it. Chin quivering. So the chin quivering he has is actually, I don't want to say pathognomonic, but it's fairly indicative of this disease. Sensory changes, gets a little tough because a lot of people can just have a mild polyneuropathy, for whatever reason that may or may not be related. And then gynecomastia, which is also tough as the population becomes more obese. But this is meant to be Kennedy disease or X-linked spinal and bulbar muscular atrophy. And so this is a genetic disease. It's fairly rare, about 1 to 2 out of every 100,000. There are founder effects in both Finland and Japan. It's an X-linked disease. It's actually a CAG repeat disease. I believe it was actually at University of Washington with Tom Bird that they first characterized the mutation. And then this is, an expansion disease, so greater than 37 repeats are pathogenic. More repeats you get, like other diseases, the earlier disease happens. So as with this patient, the onset is typically in the 40s or so. It's usually hip flexors that tend to be symmetrically affected, but you get these tremor fasciculations, decreased reflexes, and you can have fairly prominent bulbar manifestations. Sensory symptoms, often sensory symptoms that the patient may not be aware of, are a part of the disease. And then you get these non-motor manifestations, gynecomastia, reduced fertility, and testicular atrophy. You don't really, even though you get bulbar involvement, you don't really get respiratory involvement too much. And this is just a different diagram that shows it. One thing to point out on this is you get an elevated CK, which is a little bit more than you might expect with ALS. So with ALS, we're actually talking in our neuromuscular, like what's your top line cutoff for being ALS? And I don't think there's consensus on this, but when you're getting up to like a CK elevation of like 2000, you might think, okay, that's a little bit weird for ALS if it gets too much beyond that. Whereas ALS, you might get, 500 CK, things like that. But this, you have more prominent CK elevations. And then on the EMG, you do get a picture that often looks like an anterior horn cell picture, but then you also get these low snap amplitudes, low sensory amplitudes, which is a tip-off. And there's not an intervention here in terms of disease modifying. It's really supportive, but the prognosis is relatively good. So most patients are in a wheelchair by about 60. But the motor progression is fairly slow. And the life expectancy, despite bulbar involvement, is relatively normal. Okay. And so that's one that's important to keep in mind, in addition to your EMG and clinical features. It's really a genetic diagnosis that makes that. Okay, and then case 4, I believe I have 5 cases. So case 4 is a patient, 55-year-old guy, presents with some swallowing difficulties, but also arm and leg weakness. So he's got about 2.5 years of just gradually worsening swallowing difficulties, some grip weakness, some falls. When you examine, despite the swallowing difficulties, he's got normal speech, normal facial strength, does have some atrophy at the forearm, the intrinsics. And you notice that he's a little bit weak at his right hip flexor, but he's weaker at the knee extensor. His reflexes and sensory exam are normal. And so what are the tip-offs here? So the dysphagia thing is a little bit interesting, that he's got dysphagia, but not really dysarthria. It's unclear exactly how progressive it is. And then his atrophy, pretty prominent in the forearms and also kind of where his weakness is. And so your next steps, you're going to do some testing. He's really got a lower motor neuron predominant phenotype. And so, in those patients, I'm always going to be doing myopathy workup as part of it. He's got a CK that is elevated, not crazy high. And then you've got a little bit of membrane instability or acute denervation in his quads. But then you have early recruitment in the left biceps, flexor digitorum profundus, and quadriceps. Obviously, there's a little bit of electrophysiologic detail there that might not be apparent to everyone, but the early recruitment is more characteristic of a myopathy. And so really to characterize this, you've got a myopathy with kind of some limited active denervation or membrane instability. And he is NT5C1A antibody positive, and I'll talk a little bit more about that. Ultimately, with these patients, they typically would go on to receive a muscle biopsy. And what you see on that is classic rimmed vacuoles. You've got the H&E on the top and then Gomori trichrome on the bottom. And this is an example of inclusion body myositis. And in the picture here, you've got somebody who's really pretty advanced. You can see they've got very prominent atrophy of their quads in the little bit you can see of their quads. And then also they're trying to make a fist and they're not really able to kind of curl the fingers like you would expect in a normal fist. So they've got finger flexor weakness there. And so the classic presentation of inclusion body myositis is really somebody with insidious asymmetric weakness that for whatever reason really likes to affect the finger flexors and the quad. So if you've got somebody with finger flexor and quad weakness that is asymmetric, for me, this is the number one disease that I think about. Patients can be falling a lot. The time to diagnosis of this can be fairly prolonged. This is from one of the original, from Rick Barron and his group, who kind of originally had described this. So looking at 10 years, I think this is Kansas University or somewhere around there. So more prominent in males. The average age of onset was around 61. CK was mildly elevated, but again, not crazy high. Often they would have this mixed neuropathic and myopathic pattern on EMG. The EMG of these folks is really tough. I definitely still struggle with it. Tends to be asymmetric. And then ultimately muscle pathology is needed. And characteristically, I would just say they can have a lot of dysphagia, which is kind of interesting. They get this dysphagia without too much dysarthria. I mean, you can see dysarthria, but it's less common. And sometimes actually one helpful tip-off on imaging is sometimes you can see this cricopharyngeal bar when you do a swallow study. It's not pathognomonic for this. There are other things that can cause that. But if you've got somebody who you're considering a myopathy and you find that is a little bit of a tip-off. And again, these are just more pictures of the clinical features. This is from Continuum. You can see really just the finger flexor weakness, and in that top right picture, just kind of end stage where they really cannot flex at all, but they've got preservation of the lumbricals, got some quad atrophy, and then you see some MRIs of the thighs, which, I find can be a little bit misleading, but there are some things for normal versus IBM individuals. And then recently, NT5C1A has been described as an antibody that's associated with this. It is a helpful antibody, but it's not perfect. This slide is a little bit busy, but the antibody is thought to be fairly specific. It's about 99% specific, pretty good. Although at UW, I had a case of a false positive, but the sensitivity is fairly low at 57%. So you can definitely still have inclusion body and not have that antibody. And then this is this is the diagnostic criteria, probably the most widely cited diagnostic criteria for this disease. But it's sort of similar to the ALS diagnostic criteria. This is more useful for research. But basically, you need somebody who is older than 45, who's got a CK that is not super elevated, who has enough timeline of symptoms, and then you want quad and finger flexor weakness, and you want the pathologic features of it. And you can see at the bottom that there are different levels of certainty with this. There's a little bit of debate, I think, about exactly, I think with muscle diseases in general, a lot of the landscape is changing in terms of, do we muscle biopsy everyone? And the question is, if you have an NT5C1A antibody, do you necessarily need to? I guess for me, if the clinical phenotype, if they've got quad and finger flexor weakness, that's super classic. I might not always, but if there's uncertainty or it's a little bit weird, I definitely would. Unfortunately for this disease, there's really no disease modifying treatment. I mean, I could show a slide that shows everything they've tried to throw at this, but man, it's just proven refractory to everything. So, and this is an important point too, just in terms of the inflammatory myopathies. This is sort of classified as an inflammatory myopathy. And a lot of patients who were originally diagnosed as polymyositis were eventually found to have this. But this is not something that's going to respond to treatment. You're probably going to harm somebody more by doing IVIG, Rituxan, all this, all these big gun sort of treatments than you're going to help them. The life of expectancy, again, is fairly normal, sort of like Kennedy disease, but most of them are going to wind up in wheelchairs. And then, as I said, dysphagia can be a huge issue with about 50% of patients affected. Okay, I know we're running a little short on time, so I'll go quickly through the last case. This one I have not seen. This is based on some journals. So we've got a 50-year-old woman. She's got progressive weakness, cognitive issues. She has diabetes. She's from the Dominican Republic, noted weakness of her right leg. But then 6 months later, basically everything's weak. 9 months later, she's forgetful, she's confused, she's emotionally labile. Her mental status exam is really abnormal. She's slightly dysarthric. She's got a bunch of atrophy. She's weak all over. She's hyperreflexic. She's got clonus, bilateral Babinski's. You do kind of all the standard things, probably, she's upper motor neuron, lower motor neuron mixed, so probably going to do a number of different tests. EMG, looks like an anterior horn cell sort of process, but then she's going downhill fast. She's got, 20-pound weight loss. She's basically loses everything in all limbs. She's mute, only following one-step commands, and then she passes 28 months later after onset. So what are your tip-offs? Is this too fast? You do get really aggressive forms of ALS, but this is probably a bit much. And then the cognitive issues. We're recognizing more and more that ALS can affect cognition, but progression to complete mutism. It's a little bit odd. And so ultimately, this is something that autopsy helps solve. And so this is from a neurology, this old article, but it's kind of a classic from 1993. And I won't go into depth with the autopsy features, but what you're finding are these polyglucosan bodies. And in B, you've got the arrows pointed to them. And so this is polyglucosan body disease. It's a rare autosomal recessive disease, more typically found in Ashkenazi Jewish population. It's a mutation in GBE1, and it usually presents after age 40. And they've just got a lot of different things going on. So they can, develop a spastic paraplegia, sort of like ALS can do, diaphragmatic insufficiency like ALS can do, but then, neurogenic bladder, psychiatric disturbances, cognitive decline, brain MRI shows leukodystrophy. So it's just much more widespread systemic. And this is kind of, it's basically an abnormal sort of accumulation disease that happens, which this diagram shows. So it's super rare. I've never seen it, but something to keep in the differential, I think, is kind of interesting and obviously terrible disease. So those are all the slides I have. I would just say, kind of coming back to the big picture, this is really, I just want to emphasize ALS, it's a clinical diagnosis. Everyone who you're considering this diagnosis is going to need an EMG. Everyone's going to need some sort of MRI, C-spine, brain maybe, depends on the clinical picture. And then you really need to take your clinical picture and figure out what are the possible mimics and go based on that in terms of your testing. Some cases, you might consider a trial of IVIG, but really you want to do that when you've got weakness following a nerve rather than a myotome pattern, preferably somebody with GM1 antibodies, conduction block, things like that. But most of the other mimics I've talked about, I haven't presented a cure. There isn't a cure, but you might be able to present a better prognosis. So these are all my sources. And sorry, I think we're kind of running short on time, but I mean, I'm happy to answer questions if there are any. And thanks again to everyone.
Thanks so much, David.